Good afternoon. My name is Sten Vermund. I serve as Dean and the Anna Lauder Professor of Public Health at the Yale School of Public Health and also Professor of Pediatrics in the School of Medicine. And I want to welcome you to our first broadcast of COVID-19 Right Now, a weekly series of live discussion about the most pressing current issues related to the coronavirus pandemic that we're hosting here at the Yale School of Public Health. I'm joined by Dr. James Hamblin. James is a health policy lecturer here at the Yale School of Public Health and a staff writer for The Atlantic. He's also our host for COVID-19 Right Now. At this moment in history, decisions in response to the coronavirus are being made rapidly and needs are evolving. We wanted to open a dialogue with you about these evolving needs and how they impact people in all communities. In Yale and in New Haven, Connecticut specifically, we have alumni, faculty, students, residents serving to protect and improve the health of the public and the coronavirus epidemic, battling that scourge. While individual backgrounds and specialties are wide-ranging, we want to point out this is the mission of public health. This is why we have trained for our disciplines. So today and every Thursday for the next many weeks, please join James and Yale faculty and guests in a discussion about their work and the response to COVID-19. Our faculty are authoring open letters to the national government, to the media, interpreting data in real time, analyzing both the immediate and long-term effects of this virus, prognosticating, forecasting, developing new novel assays, working on clinical protocols to find treatments, trying to unravel the immunology of this condition, not to mention the policy issues around social distancing and the devastating economic impacts that has inherently. So many of our faculty work in active healthcare facilities and research labs. All of us are trying to move the conversations in the direction of facts, best practices, evidence-based, and we recognize that more data are needed to address this global pandemic. So please share your questions in the available comment section of this weekly series, and we hope to get to your questions because we're really here to engage with you. We want to encourage you to stay healthy and to stay connected to the Yale School of Public Health. I'm now turning it over to you, James.
Thank you, Sten. It's an honor to be part of the team. And we are going to do our best to engage here and to take questions and it feels like the news is evolving so quickly that what you say one day is barely even relevant the next. And so we thought it would be good to just go live and hear what's on everyone's minds and engage in real time. And someone I've been talking to almost daily for the last few months about this and following, you probably follow him on Twitter and have seen his various media appearances recently because he's become a leading national voice in this, is Howard Forman, Howie. He's a professor of public health and management and a practicing radiologist at Yale New Haven Hospital. And he's been a longtime mentor to me. So we can have this discussion, and he knows the numbers extremely well and has been a brilliant forecaster of what they mean. So I keep asking him to tell me what to make sense of everything. Thank you for joining, Howie.
Thanks for having me.
Could we start by just, I always want to hear, you are so good at identifying the signal from the noise about where we are and what people should be most keeping an eye on, what can be done. What's at the top of your mind as you follow the news today?
Right. So I think, we're obviously in the midst of a global pandemic, and up until several weeks ago, people felt it was limited to China and then South Korea and a few other tiny cases here and there. And somehow people believe this could be contained. But then over the last several weeks, we've watched several hotspots explode, both in the United States as well as globally. And I think the places to watch most closely right now on the global scale has been Italy and Spain, and quite frankly, several other countries that are smaller but also have increasing caseloads and very high death rates, but particularly Italy and Spain. Italy right now seems to have flattened the curve a little bit. They had a really good day yesterday, today a little bit less good, but still substantially fewer cases than we would have predicted just 5 days ago. So we think they've continued flattening the curve. Death rates in Italy have come down a little bit over the last few days. So that may be good news because Italy does look to be about 2 weeks ahead of a place like New York. In the United States, the biggest hotspot is New York, but it's not alone. It's just a very populous and dense hotspot. And so we look out there and we see places like Louisiana and Michigan as exploding hotspots, not to mention larger caseloads, even if lower death rates in places like Massachusetts and multiple areas within California. And so I think we watch these numbers day to day to sort of give us hope and to give us some direction about how we make policy changes that can help us to continue to mitigate and suppress cases here and allow us to get through the most acute phase.
I want to hear I'm in New York, and so I feel like I'm at the front lines of this global war. What are we doing wrong right now? What needs to happen most urgently here?
So, yeah, I think in terms of the category of wrong, I think that one of the things we've learned through this whole period is by the time you see even a single case or a few cases pop up in your hospitals, you basically have an enormous epidemic, because one of the things that people need to understand is that there's basically a 5-day average incubation period, and there's also about 3 to 5 days to get a test back. So by the time you get a test back telling you that somebody has this, you're at least 10 days behind. And if they present it in a severe state, you may be as many as 18 or 19 days behind. So you're backward looking at all times. You're always looking at figures coming out that are telling you what the status was 1, 2, even 3 weeks ago from now. So as soon as you see even the tiniest outbreak, you should assume that it's much larger than that. And I think the lesson that we could have learned from the Westchester super spreader was that as soon as we saw 1 or 2 cases in Westchester, we should have probably shut down New Rochelle and areas around it immediately, and probably even considered shutting down Fairfield County and New York at the same time. And then we would have been much further ahead and probably not had this enormous growth of cases that is overwhelming many hospitals in the New York area right now.
Right. Should New York be more shut down than it is?
So I'm not living in New York right now, and you know, I grew up in New York, as you know, and I talked to my close friend Molly in New York all the time, and up until several days ago, she would tell me that New York wasn't listening, and it was very frustrating to her, and she felt that it was not shut down enough. I am told that it's much quieter now than it was. Here in New Haven, I think that the community has really taken this very, very seriously from several days before the New York outbreak started to explode. So all I would say is it's hard to know how much to shut a place down, but to the extent that you can have people truly not interacting with one another more than 6 feet, having as minimal time in the same room with other people as you can, the better off you are.
Right, right. People seemed it seemed like there were a few days where the nation got behind this, the administration got behind, we're going to social distance, we're going to shut down, and very quickly there was a strong movement that we got tired of this. This is totally ridiculous economically. We need to open things back up. And what would happen if we open things back up? Right.
So the same thing in reverse is that it takes us 2 weeks plus to actually see the effects of policy change. So right now, for instance, in New York, where the caseload is increasing every day, in other words, each day has more cases than the day before, each day has more deaths than the day before. If we were to ease up now, some of the benefit from the last 2 weeks that might have been showing up within the next week will probably show up, but then a week later it will explode again. And to the extent that we can't clear patients out of the hospital, and it does seem that COVID-19 patients linger in the hospital for longer if they survive even, but they spend more time on a ventilator, more time in the ICU. To the extent that happens, we will really overwhelm our system. The time to ease up is when you have complete control of caseload and where you can ease up in a slow, measured manner and watch with 2-week lags to see what the effect is of those policy changes.
Yeah. So people keep asking me, how long do I have to stay at home inside? And I'm sympathetic to that, especially, you know, in New York, it is different. We have extremely tiny places, and people come here because they want to use the shared social spaces, and that's where you live disproportionate amount of your life. I know I don't have an answer to that, because it says, you know, it depends how things go, and we'll see what the data show. But how do you appropriately temper people's expectations without saying you may need to be living without leaving your tiny apartment for months? And that seems impossible.
This is one of those times where we really need to encourage people to understand delayed gratification. This is where, if we can put this off the right amount of time, we will save ourselves so much pain, and we'll probably spend less time in this state if we can do that. What I'm confident about is it's not April 12th. April 12th may be a very good day to assess where we are and to start to think about plans into the future. In my mind, and maybe this is pure optimism, I've said to people that I think sometime between May 1st and June 1st, we may be able to start easing up on some measures. We may be able to look out there and see which cities are sort of past the peak, and maybe you can ease up on some things, what cities are getting worse and may actually need even tighter controls. I also think that over the next several weeks, more information is going to flow in as we increase our testing capacity, and hopefully also transition to antibody testing, that type of information will inform to such a great degree our ability to make these decisions.
Right, right. The antibody testing is super interesting to me, because especially as we have a shortage of healthcare professionals, or we're trying to really hard to limit uses of PPE and things that will be in short supply. If you had people who you knew were immune, or believed we had a very high likelihood of not being able to contract the disease, that would change the way that they're able to operate in the world. How far away are we from having a test like that could be reliably deployed?
So there are companies that already have such tests and that have the ability to market and sell. I myself have no insight into how accurate they are, or whether what they're selling really works or not. But I imagine that in the next few weeks, those answers will come through. I mean, the impact of what you just described cannot be overstated. I mean, it is a huge opportunity for us. It's a huge opportunity, not just for public health and the health of people, but it's also a huge opportunity for our economy, because if we could identify millions of people who have already been exposed, have recovered, and now have antibodies and therefore are immune, it not only means that they're protected, it means that they can't transmit the virus either, presumably. And those things make those people incredibly valuable to starting up our economy, to providing care to elderly people, to being able to deliver goods and services to elderly people who are otherwise frightened right now and who need such services. So, I can't, I've been on the bandwagon of testing from pretty much day one of our discussing this epidemic, but I think the antibody testing is the next wave that we need to be talking about.
Yeah. Well, so that goes through an FDA approval process, no? Or is that underway?
As I understand that some of these are actually approved somewhere. I think it's more about validating them. I don't think the test itself has to be approved so much as it has to be validated against some type of standard. This is not my area of expertise at all, but I do think it's a short time frame. It's certainly not in the time frame of vaccine development.
Yeah. No, I understand you would not want to deploy a test like that turned out not to be very reliable either, because guys are putting a lot of weight on it. People could die if it's not. Okay. Well, I hope that there's a fair number of people who we find have experienced a disease that was mild enough that they did not even know that they, or don't even believe that they had it, or weren't. But do you have reason? There's still a part of me, a lingering hope, that this number of either asymptomatic or very mild cases is greater than we understand, because most of the world has not been testing widely. Do you have any lingering hope of that, or?
I do. I mean, I think the reason why I don't have extraordinary hope and why I'm a little dismissive of those who think that there's this extremely large number of asymptomatic mild carriers is that we have the experience of the Diamond Princess cruise line. We have the experience in South Korea where they have tested vastly. And so the only way that could be true is if the PCR testing for the virus itself turns out to be very non-sensitive, and therefore a lot of cases have slipped through that we didn't know about, that were infected, that we weren't able to count. If you assume that the PCR testing was fairly sensitive, it would be hard to imagine, given the fact that we've done such vast testing in South Korea, we've been doing vast testing in areas of Washington State, certainly in the Diamond Princess cruise line. And those numbers would suggest that while there are a lot of asymptomatic or mildly symptomatic carriers, it's not nearly as big as we think.
Okay. Not in South Korea, were they testing people who had no symptoms at all, just contacts and whatnot?
Yeah, they did. They did an amazing amount. I can't pronounce the name, but the religious sect that was the focus of infection in Daegu, where missionaries had come back from Wuhan and basically spread it in a super spreader manner. They ended up testing tens of thousands of these people who did not have symptoms to screen for them. They watched them for symptoms as well. And they've continued testing at a vast rate so that they're still testing 7,000 people a day in South Korea and only coming back with like 100 or 105 cases. So they're still doing an enormous number of tests compared with their caseload that they're finding.
Yeah. Do you think the difference between them and us was one of public health infrastructure or political will and motivation, or both?
And fear.
Fear.
And fear.
Yeah.
I've recently come across an article that I've used in some of my tweets to explain this, but I talk about the fact that China went under a real lockdown in, I think, January 20th or 22nd. In Korea, there was no real lockdown, but there was this article that describes that on like February 20th or something, the streets of Daegu were a ghost town and that people were just scared to go out and nobody was out there. And they described it as like, I think the words in the article were that there was a zombie apocalypse. So once you don't need necessarily even the government if there's enough fear in the community.
What created that fear though? How are Americans not seeing the scenes from Wuhan and Italy and feeling fear? I mean, many are, but many are not.
I think my understanding is that South Korea did experience some of the MERS epidemic, and even though it was small, it was very lethal, and SARS as well in that region. And I think that a lot of individuals in that area take these pandemic spreads much more seriously than we do. We really haven't had something of this magnitude in this country ever, quite frankly. Ebola was brief, it was a burst, it affected very few people, even though it was scary. Most other things have been basically flu pandemics, and even though those have been widespread, we had one in the 50s and we had one in 2008 and 2009, and most of the others have been milder episodes. This is the first time in my lifetime, certainly, that we've had something of this magnitude, and I think it's going to linger with people.
Yeah. People have to experience this firsthand, or else they believe that the American exceptionalism will continue. Yeah. Tragic that it had to come to this. We have reader questions. Great. If anyone else is watching, would like to ask a question, we would love to answer it or try to. First one is from Naomi Taylor. How are we as a country doing generating enough testing capacity?
Yeah, so I think, I didn't check the numbers yet. They come out around this time today, but as of I think yesterday, we were doing 74,000 tests a day. It's been going up by about 7,000 tests a day. I'm hoping that today it's 81 or 82 or maybe a little more than that. 2 weeks ago, and this was a back of the envelope estimate, I thought we should have been doing about 100,000 tests a day. Now I think it's probably more like 200 or more. So, but we're getting much closer to where we need to be for what I would consider barely adequate testing. But it's hugely variable. In the state of Connecticut, where many of us live, we are not able to test a large number of people who absolutely need tests, including healthcare providers. Whereas in the state of Washington, the University of Washington very nicely publishes their results every day, their virology lab, and their virology lab is testing less than 60% of their capacity. And that's very frustrating. It's one of the reasons why I think calls for coordination between federal government and state government would be so helpful, because it would be nice for us to be able to say, okay, Connecticut can't test enough, but maybe Massachusetts can, or maybe Washington State can.
Yeah. But at this point, if you're Washington State, you're a university hospital, you're admitting people with appendicitis, with a broken arm, during this time of pandemic where there's this long incubation period. Why don't you just test everyone who comes into the hospital?
No, I'm with you there. I think that there would be so much good in doing surveillance testing, prevalence testing. And honestly, the problem with that now is that we may have missed so many people that we don't even, it's not going to help us as much now as it might have if we were doing it aggressively from the beginning, which is why the antibody testing starts becoming so important. But I agree with you. We are putting people at risk when we have so much spread by taking people into the hospital for even semi-elective things like cancer surgeries, which we're still doing, by the way, but where we're doing a cancer surgery that may be putting somebody at greater risk if it turns out that they've already been infected and just pre-symptomatic.
Right. I know you practice at Yale New Haven and can't share specific data, but I assume there is a significant change over the past month in the way things are being conducted. Are people being screened outside now, or anything to that effect?
So my understanding, mostly from the press, is that we're setting up sort of testing in parking lots, both at the Yale New Haven campus and the Bridgeport campus. I don't know if we're actually there yet, but we're setting it up. I will say, and this is very heartening to me, that what I've watched and heard about from talking to my colleagues is just this enormous transformation of a health system into one that is ready for an enormous caseload, and they see the caseload coming, and they've transformed floors that were previously used for other reasons into COVID floors. They've prepared ICUs. They've gotten physician labor lined up so that when the volume continues to increase, they can rapidly onboard people who ordinarily aren't working in ICUs into ICU care. It's very, you can be very proud of an institution when you see them preparing so much over the weeks leading up to this, getting ready for what is now obviously a big wave.
Yeah, that's something I specifically wanted to, where do you think the weakest links in our supply, in our personnel supply are, in terms of not everyone needs to be a doctor. We can have a lot of people who could check vital signs and order an X-ray, monitor oxygen levels. At what level of training could we best bolster that workforce to make sure there's enough people?
Yeah, look, there have been calls out. I'm still licensed in the state of New York, so I got their letter, I think today, asking whether I was willing to come back into New York or to New York to care for patients and what my capacity is and what skills I have. So the states do see this as a critical need. The state of Connecticut and federal law have made it a lot easier now for different physicians to practice outside of their usual scope of care in order to help with this. The needs that we have are so vast that even people that have no healthcare background could be brought into service for screening purposes, for even checking information on patients and taking care of patients as part of the screening process. And I don't think we've done a particularly good job of this, and this is not, our acute care health systems are not set up to do public health screening, and our public health departments in our states are not set up for widespread pandemic management. This is where I think of all the lessons we could learn, I hope that one of the lessons is that our federal government needs to take a much stronger role in activating personnel in all states, moving personnel between states, and as Governor Cuomo has mentioned, even moving equipment between states, so that states that have a very, very high need for ventilators right now, in 4 weeks might have a much lower need, and they could move those ventilators around. We have thousands of planes that are idled and pilots that are idled. We have the capacity to move things around this country to a degree that we ordinarily would not have. And I don't see us centrally controlling those logistics in a way that we really could.
What agency would do that?
You know, I don't work in the federal government, but I imagine that using FEMA and the CDC could actually coordinate. That's what we've done during hurricanes and other national catastrophes and emergencies. But I think this is where you would want to have a task force that coordinated between the CDC and FEMA and maybe other health agencies to be able to do this type of work.
Yeah. Oh, we have more questions. Great. Aaron Cushing asks, do you think grocery stores are hotspots for transmission? I'm getting that question a lot. And how about closing all non-essential businesses and making groceries pickup or delivery only?
I don't have a good answer for that. I would ask other people that one. I would love to know the answer to that myself.
Yeah. You know, I know in China they did food delivery only. And I also think every time we send people out to do delivery, we are asking them to risk themselves instead of us. So the advice I've been giving based on what no one has an authoritative answer, but that if you can go out the less frequently you can go out, the better. And then, buy a bigger haul than you normally would. So you can go out more frequently, not because you should be hoarding.
Right.
And then that there's time on your side too. If you drive a car and can, keep things in the trunk for a few days, just in case there was anything on there, it should die versus trying to meticulously sanitize everything.
I may be falsely optimistic about this, but I happen to think there's less transmission off of just simple surfaces as opposed to a surface where someone's actively sneezing or an emergency room. One of the things that people have talked about is whether this is spread by aerosol or by droplet. And one of the things that sort of comforts me a little bit is that if it was spread by aerosol, if it was on all these surfaces, I think all of us in the hospital would already have it and we would know that we have it. And so I'm a little comforted by that, but maybe false hope.
Yeah. Are you using negative pressure rooms still for people or no?
I believe we are. We're certainly doing that on our COVID floors. But what I mean is that I work out of an emergency room, and certainly our waiting room is not negative pressure. Our overall emergency room is not negative pressure. And I would have thought that if we were going to have that type of massive spread, the way you expect with aerosol, we would have seen it much worse.
Right. Okay. Please comment on the sensitivity of the tests, false positives from the United States tests, and what lessons should we learn to be prepared for next time? So I guess that's very two distinct questions.
Yeah, this is frustrating. You and I have talked about this several times. I talk to people all the time to say, what is the sensitivity of this test? We believe the specificity is very high, but in terms of sensitivity, it's all over the map. There are people that talk about it being down in the 50% range. There are people that say 70%. Then you hear Dr. Birx on TV saying that it's a perfect test, or maybe that was the president. I don't know. I'm really frustrated by the lack of information. It would seem to me that by this point in time that there would be some data that would tell us more precisely what the sensitivity is.
Yeah, I know Albert Koh has told me, he directed me to some Chinese data that was 30 to 50% was initially what they were saying for sensitivity. And so they were definitely always testing twice. And that when you tested twice, with clinical correlation, one of your favorite terms, that
Yeah.
you could get it, you could have a pretty good sensitivity. And then Dr. Fauci used to recommend always that you test twice, but then when we started to scale testing more widely, it's suddenly fallen out of the conversation. But it would seem that you could not rule it out until 2 tests. But I've also talked to people who've gone through these drive-through testing clinics. A friend of mine did it 5 days ago, no result. What good is that, especially if you have to go back and get another test?
That's right.
So anyway.
This is why the availability of at-home and fast, rapid testing that seems to be coming online right now from private companies, if it's sensitive and specific, could be a game changer.
Yeah, it seems it wouldn't have to be that sensitive to to be better, or to be at least valuable.
Yes.
But yeah, as I understand, it's a diagnostic test, just like any. It demands clinical correlation, and the value of it changes depending on whether a person is coughing and sick or not. From Evie, I'm sorry. What are some universal truths that we can learn from China and Korea? Testing, lockdowns, anything else?
Yeah, I think we've identified, one of the things, the patterns that I have observed and we sort of plotted out now is that it's almost exactly 13 days from the day that you do either a legal or a de facto lockdown to the day that you see a drop you basically peak on day 13 or 12, and then you start to drop off after that and start to flatten the curve. So we know that there's that big a lag. And so you've got to get ahead of this.
Mm-hmm.
Like, you've got to be doing the lockdowns as early as possible. And then, quite frankly, in the current environment, if it doesn't peak up too high for your area, you will have lost a few days of commerce, but not more, because then you can ease up on the levers and watch what happens, and you'll learn from other places that have been through it. But if you don't get ahead of it, you're going to be losing people's lives.
Right. There are a lot of people in the public health community who, if there is this spectrum between people's concerns about finances and people's concern about virus spread, the public health community tends to lean toward just prevent measures that do more to prevent virus spread, more shutting down. And obviously everyone's concerned about economic problems too, but if there's a discussion there, and you are a professor in the School of Management, you know more about healthcare economics than probably anybody I've ever spoken to. You understand and appreciate completely the economic ramifications of what's being suggested, and yet you are fully in the camp of aggressive shutdowns being needed. I know that the fiscal policy for how to make that sustainable for a country is complicated, but are we doing enough? Is $2 trillion enough, or how is that ever?
So a couple of things. First of all, even if the loss of life itself was not a reason to do this, when you see what it's doing to our health systems in states like New York and Michigan and Louisiana and so on, there's no way that you can't believe that what we're doing is the right thing. The only question is whether we did it early enough or whether we may have wasted part of the opportunity. As far as how you correct for this and how do you maintain the economy so that we don't completely implode, we learned through the Great Recession that we have fiscal and monetary levers that are available to us that do allow us to self-correct a little bit. And remember, the difference between 2007 through 2009 and now is that our economy fundamentally is not the problem. It's not a structural problem in our finance system. It's not a structural problem in how mortgages are financed and so on. This is a public health catastrophe. And so printing money in this environment and running up a debt in this environment seems like a very prudent approach, and one that once this is over will allow us to emerge. It may not be a full V-shaped recovery, but it will not be the very, very long recovery that the last took because we just don't have the same structural problems.
Yeah. But do you think that the measures that have been taken so far are enough? overkill to the financial policy?
So the one area that we look most closely at is hospital costs. And so we were sort of impressed by the fact that our best estimate and we have an article in the Philadelphia Inquirer today with my colleague Joe Cavallo and a former student, Ben Albright. And we did our own estimate of sort of what hospitals are losing during this period. And the stimulus bill has a number that's almost precisely in line with what our number is. So I sort of feel like they have it right to the extent that anybody can predict what the next few months are going to look like. If this carries on longer than that, you may need more fiscal stimulus, but Congress can be brought back to action very quickly if necessary.
Yeah. Yeah. It's a unique moment of bipartisan action behind this. It was 100 to 0 was the bet, right? Okay, one final question, because I am interested in this myself. If you live in New York City, do you think it's a good idea to leave the city and go home, depending, I guess, if you have another home, if you quarantine yourself for 2 weeks?
Yeah, I've been asked that so many times by so many people. The reason not to want to be in New York City is if you're a vulnerable person to begin with, and an elderly person or have comorbidities or lung disease, and you're worried about if something were to happen to you, how you deal with the hospitals at that point. If you need to leave, I think that's the right way to go. You quarantine for a week or 2 weeks. For the most part, most infections occur within 5 or 6 days. So, I think you can start to become more rest assured once you pass day 5 or day 6 from the last contact you've had with anyone outside. It's very difficult to maintain a full quarantine. As we all know, we go into workspaces where we touch desks and things that aren't our own. We watch our hands as much as we can, but it's never enough.
Yeah. Well, it just becomes, this is why the forecasting, I think, is helpful to people. So if I could say you can make it through 2 weeks in your little studio apartment, but if you're needing to live for a year, people would just plan to leave the city, because not only is it extremely expensive, but it will, create all these other health issues that you simply don't have a place to move around, don't even have a treadmill in the basement.
That's right.
Is there anything else you wanted to come back to before we close the session, or to
No, I would say that someone asked me today, I was doing a podcast, they asked me today, like, where does my hope come from? My hope comes from a few things, that if we massively test, we'll have a better handle on where we are and what we can do going forward. There are hundreds of clinical trials going on and testing trials going on that are going to allow us to do a lot of different things over the next 4 to 8 weeks that might have an impact on the disease course. And once we get over the hump in major cities and get our health system back under control and get access to protective patient equipment, personal protective equipment rather, we will be able to do a lot more. And so to me, there's a lot of hope in some patience on the part of everybody to get through this period.
Yeah. Thank you. That is really hopeful. You were on a podcast today. Hopefully you'll come on my podcast also.
I would happily do that. Thanks, James.
Do that? Okay. Thank you so much for talking in this inaugural episode. And hopefully we'll do this again soon.
Sounds good. Great.
All right. Thanks so
Take care,
much.
everybody.
Bye, everyone.
Stay well.